We know that osimertinib with or without chemotherapy can produce a good number, maybe a third, of patients, can get a major pathological response. So HER2 mutations can occur, probably in about 3-4% non-small cell lung cancer, more common in never smokers. So for KRAS G12C mutations, we have two drugs that are FDA approved, adagrasib and sotorasib. However, they are not long-lasting. 6 to 8 months, you can expect that patients are going to progress.
Why is Tarlatamab better than chemo for second-line small cell lung cancer? And how do you handle its side effects?
Yeah, so Tarlatamab is a new agent. It's a bispecific antibody that targets DLL3. And it has a overall survival demonstrated improvement, compared to chemotherapy. So small cell lung cancer is a devastating disease, and when it recurred, it basically takes your life very quickly. So having a new agent like this that is able to prolong overall survival is really very welcome. We do have to handle the side effects. As all agents that stimulate the immune system can create storms, and that's what we call cytokine release syndrome. And we have to observe patients, very carefully. Once the patients go after 2 cycles, the chances that this will develop or that they will be serious is very small. So, but at the beginning, we have to be very careful with the potential toxicities. Do preemptive. We have to do dose steps. Increase the dose as we go. A trial at the beginning with a small dose, and then we increase it. So, anyway, but in general, most patients are able. An overwhelming majority of patients are able to continue on the therapy and not discontinuing.
For early EGFR-mutant lung cancer, does osimertinib before surgery really help long-term survival?
We don't know that yet because the trials that were performed, the major endpoint was pathological measured responses. And we know that osimertinib with or without chemotherapy can produce a good number, maybe a third, of patients, can get a major pathological response, which that's an advantage. And there is about a 50% or so that can have a nodal downstaging. So that's basically so far what we know. We do not know if the neoadjuvant, since we already are using it in the adjuvant setting, is going to change or make an impact in overall survival. It's still early for that. But nevertheless, as we move more into early therapies and do neoadjuvant therapy, as we, for example, are doing with immune checkpoint inhibitors and chemotherapy, I think this trial that was presented at ASCO, it really is very promising.
How do new drugs like Zipalertinib or Zipalertinib change treatment for specific gene mutations in advanced lung cancer?
So we the most common mutations, as you know, that we have in lung cancer are EGFR mutations and ALK translocations, fusions. And for those, we have a number of agents, TKIs, that have been very successful in improving overall survival, progression-free survival, and have become a standard of care. Now, there are some other mutations that are, more rare. And one of them is HER2 mutations. So HER2 mutations can occur, probably in about 3-4% non-small cell lung cancer, more common in never smokers. And so far, we do have treatments that we have given these patients, typically chemotherapy or chemotherapy plus immunotherapy. However, we have a target, and trastuzumab deruxtecan, have been approved, for this, which is an infusion, and it's a chemotherapy that goes into the tumor. But these drugs that you mentioned are oral agents. They are tyrosine kinase inhibitors, and for the first time, we are showing that they could be really as effective as a trastuzumab deruxtecan, and the toxicity profile appears to be lesser. Osimertinib has been approved, FDA approved, for the treatment, so it will be available to patients. And it is very likely that we're going to be using that, earlier and earlier. So probably can it replace chemoimmunotherapy? Very possible.
Why combine adagrasib with pembrolizumab for KRAS mutant lung cancer, even with extra side effects?
So for KRAS G12C mutations, we have two drugs that are FDA approved, adagrasib and sotorasib. And they do produce responses, in patients. However, they are not long-lasting. So, 6 to 8 months, you can expect that patients are going to progress. So, KRAS mutant patients have been shown to be responsive to immune checkpoint inhibitors. Again, in the first-line setting, we use them together with chemotherapy. So the question is, can the immune checkpoint inhibitors add to what adagrasib, for example, can do? So this trial that was presented at ASCO looked at combining, these two agents, adagrasib and pembrolizumab, and see if basically you will augment the clinical outcomes. And the response rate, when you take the overall group, it was moderate, along what you would expect with adagrasib alone. But for patients that are PD-L1 positive specifically, the progression-free survival appears to be increased. Again, this was not a randomized study, so we cannot really compare. But based on this study, it looked like for those patients that have high PD-L1 expression and have a KRAS G12C, this could be a potential approach. However, we have to deal with toxicity, and liver toxicity is one of the toxicity that appears. It can be handled with steroids. You can re-challenge the patients if they develop that. However, we need more studies. We don't know how would that compare in a randomized trial with adagrasib alone or with immune checkpoint inhibitors alone in patients that have more than 50% expression.